Hello, this is Spencer, oncology pharmacy resident, and for this clinical pro, I'll be talking about olanzapine as an antiemetic and going over an MUE that I conducted at the beginning part of this year. Getting into the background on chemotherapy-induced nausea and vomiting, it's actually estimated that around 70 to 80% of patients who receive chemotherapy will experience some degree of chemotherapy-induced nausea and vomiting during the course of their treatment, which can have a negative impact on their quality of life. Of those who do experience chemotherapy-induced nausea and vomiting, 25 to 50% of those patients will actually delay or refuse possible life-saving anti-neoplastic therapy due to failure to control chemotherapy-induced nausea and vomiting. Getting into olanzapine as an antiemetic, in 2017 it was actually added to the ASCO and NCCN antiemetic guidelines as part of a preferred treatment regimen for high emetic potential chemotherapy. It has been shown to be highly effective but does come with the side effect of sedation. For its effectiveness in acute and delayed nausea, olanzapine compared to placebo resulted in 86 versus 65% and 67 versus 52% of patients experiencing a complete response, meaning that they did not have one episode of nausea or vomiting and did not need to use any medication for breakthrough nausea and vomiting. As it is a relatively new medication with regards to being used as an antiemetic, its optimal dose is still inconclusive. It was originally studied at a dose of 10 milligrams daily for 4 days, but recent studies have shown that doses of 5 milligrams daily for 4 days is as effective with less sedation. The most recent study was published in 2019 and compared olanzapine 5 milligrams daily for 4 days to placebo. It was found that 79.1% of patients who used olanzapine were able to reach a complete response in the delayed phase. These patients also noted better sleep as well as less severe sedation. At the time of this MUE, when we were regional health, the antiemetic regimen for high emetic chemotherapy included olanzapine 10 milligrams daily for 4 days. So the purpose of this MUE was to evaluate the effectiveness and adverse events reported with the use of olanzapine 10 milligrams in antiemetic regimens. The secondary objectives were to evaluate the efficacy and adverse events of olanzapine 5 milligrams for those patients who were started on a dose of 5 milligrams. The next being to evaluate the efficacy and adverse events of olanzapine 5 milligrams following a reduction from olanzapine 10 milligrams due to an adverse event, and then compare the efficacy and safety of olanzapine 5 milligrams and 10 milligrams. Getting into the study design, so this was a pure retrospective chart review of cancer patients who were prescribed olanzapine as an antiemetic between August 1st of 2018. It included patients greater than 18 years of age receiving chemotherapy with no prior use of olanzapine. For this MUE, we were able to find 93 patients who were treated with olanzapine, the mean age being 59, 72% female, with the majority of cancer diagnosis being breast. In Table 2, we can see a chemotherapy breakdown with olanzapine being used as part of that antiemetic regimen upfront for high emetic potential chemotherapies. Then on the lower half, these regimens being not highly emetic, so olanzapine not being used as upfront. But if the patient did experience failure while on a moderate emetic potential regimen, then olanzapine could be added on. Getting into the outcomes, Figure 1 shows the primary objective of olanzapine 10 milligrams efficacy. Of the 93 patients that we were able to find for this MUE, 91 of them were started on a dose of 10 milligrams. In the most left pie chart, we can see the therapy success rate of 71% with a 29% failure rate. And then that 29% failure rate is broken down into if the patient experienced just nausea or nausea and vomiting, with 18% of the patients experiencing just nausea and 8% of them experiencing nausea and vomiting together. Figure 2 shows a secondary objective, olanzapine 5 milligram efficacy. So only 2 patients were started on a dose of 5 milligrams, but these patients did have 100% therapy success rates. Table 4 gets into dose adjustments and outcomes. As you can see by that first row there, the number of patients requiring adjustment was 11, so around 12% of the patients did require a dose adjustment. And then under that shows what the adjustment was as well as the impact. 7 of the 11 patients did have their olanzapine discontinued due to the adverse effect. In 2 of the 7 patients, there was an increase in nausea, but no sedation since we did stop the olanzapine. In 2 of the patients, there were similar rates of nausea as when the olanzapine was on board. And 3 of the 7 patients experienced no nausea and no sedation. 3 of the 11 patients had their olanzapine dose reduced from 10 milligrams to 5 milligrams. In the outcomes of that dose reduction, there was no increase in nausea and no sedation. 1 of the 11 patients had their duration of olanzapine decreased from 4 days to 3 days, and the result was no nausea and less sedation. Table 5 compares the safety of olanzapine 10 milligrams and olanzapine 5 milligrams. The events that we looked at were moderate and severe sedation, fatigue, and dizziness. In the olanzapine 10 milligram group, 35 of the patients, or 37.6%, whereas for the olanzapine 5 milligram group, only 1 patient experienced one of these events. With the results of this MUE, we were able to see that our current practice did align with what was reported in previous trials. So in this MUE, 71% of patients were able to achieve a complete response for delayed nausea as compared to 67% in published trials. The 2 patients who were started on olanzapine at a dose of 5 milligrams did not experience any nausea or sedation. The 3 patients who had their olanzapine dose decrease from 10 to 5 milligrams didn't experience any additional nausea or sedation. And the rate of sedation with olanzapine 10 milligrams was consistent with other reported rates of sedation. So 37.6 in this MUE compared to 20 to 39%, which was reported in LexiComp. After further analysis of these patients, it was found that 57% of the safety events with olanzapine 10 were in patients greater than or equal to 60 years old, and 60% of patients with a moderate to severe event with olanzapine 10 milligram also had greater than or equal to 3 medications known to cause sedation on their medication list. There were some limitations to this MUE, however. Number 1 being it was a retrospective chart review. There was a small sample of patients who were started and switched to 5 milligrams of olanzapine. We were unable to assess compliance to antiemetics, as well as unable to assess breakthrough antiemetic use, and unable to assess the use of their concurrent sedating medications since most of these were PRN. Also, we were relying on reporting of sedation, which there could be subjective reporting as well as lack of reporting. Future directions that we took away from this MUE was that more data would be needed in order to change our current antiemetic guideline for all the patients. But one thing that we did want to look at was any patients who were greater than or equal to 60 years of age and those with greater than 3 sedating medications to be further reviewed for appropriateness to possibly start olanzapine at a lower dose, since these are the patients that did most often experience an adverse event with the 10 milligrams of olanzapine. Also gave us insight on provider management of adverse events within our institution and the opportunity for provider education. So those patients who had olanzapine discontinued altogether due to an adverse event, potentially decreasing their dose to 5 milligrams instead of discontinuing it altogether. Once again, thank you for your time. I hope you took away some beneficial information about olanzapine as an antiemetic. And again, if there are any questions, please feel free to reach out to me at sleeman1@monument.health. Thanks and have a great day.